Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into this latest video. This procedure is of a patient who attended with a cholesteatoma. Now, this is the patient's right ear. We didn't perform any treatment per se, but you can just see the top part of the eardrum. It looks abnormal, and I'm going to come back to that in a moment. But this patient also had a cholesteatoma previously in the right ear, and it's eroded the top part of the ear canal, and it's exposed all the middle ear structures. So here we can see the hammer bone, we can see the lateral process of the hammer bone, the neck of the hammer bone, the head of the hammer bone, and we can also see the anvil, which is including the body of the anvil. So we call the anvil the incus, the short limb of the incus, and the long limb of the incus. So what is a cholesteatoma now? I'm going to talk about a cholesteatoma whilst I'm showing you the procedure in the. Now at this stage I wasn't aware whether or not the patient had a cholesteatoma also in the left ear. It's very difficult to ascertain. So you'll see me in this left ear being very gentle, very delicate, because with a cholesteatoma you do have to be that. Sometimes a cholesteatoma needs to be removed surgically following a CT scan and general anaesthetic. You can see there's a medial lump of hard dead skin, so keratin, and there's a bit of pus there, so what we call otalgia. So the first few minutes I'm almost sparring with the left ear. I'm just kind of analysing the ear. I'm just touching the crust of dead skin, looking at the patient's reaction. I want to make sure it's not uncomfortable. Because I'm not 100% sure whether this is a cholesteatoma at this stage. It could just be a collection of dead skin that's medially impacted against the eardrum. So whilst you're watching this, I'm going to explain what a cholesteatoma is. So a cholesteatoma is a collection of dead skin, so keratin, that usually collects at the top part of the eardrum. So when your eardrum is retracted or inverted, so sucked inwards, buckled inwards, it normally gets sucked in at the top of the eardrum, and that's called the attic. We also call that the pars flaccida. So that region of the eardrum is very, very mobile, very thin compared to the main body of the eardrum, which we call the pars tensa. So the clue is in the name, pars tensa. So the eardrum's a bit more tense, it's a bit more muscular in the main body of the eardrum, but at the top part of the eardrum, so specifically the posterior superior quadrant, you tend to get a retraction pocket if you've got a blocked eustachian tube. So the eustachian tube is a small tube, small orifice, which connects the middle ear. So the middle ear is the cavity behind the eardrum to the back of the nose. And the eustachian tube has two functions. The first function, it acts like a drain pipe. So any fluid that's secreted in the middle ear by the middle ear mucosa, so that's the layer of skin that lines the middle ear. That middle ear mucosa secretions, all the fluid can drain away out of the eustachian tube at the back of the nose. But the eustachian tube is also the pressure equalizer in the ear. Ideally, we want the air pressure behind the eardrum to be equal to the air pressure in the atmosphere. And when the air pressure either side of the eardrum is equal, that's when the eardrum is at its most mobile, and that's when we hear the best. So that eustachian tube from the back of the nose, it can regulate the air pressure. Now if the eustachian tube gets blocked, and it normally gets blocked at the back of the nose, so in the nasopharynx region, it creates a vacuum. There's no air behind the eardrum. All the remaining air that was previously behind the eardrum in the middle ear cavity gets sucked up by all the cells in the middle ear mucosa. And that causes a suction effect. It's a vacuum, your eardrum gets sucked in, and typically it's the top part of the eardrum, the attic, the pars flaccida, because that's a bit more gentle, it's a bit more flexible, it's a bit more flaccid, hence the name pars flaccida. And when the top part of the eardrum gets sucked in, it creates a pocket, it creates a little cave. And so if you've been watching my videos, you'll realise that the ear canal is lined with a thin layer of skin, and that skin also coats the outer part of the eardrum. And as that skin dies, starting from the eardrum, it naturally moves sideways and outwards towards the entrance of the ear. So the ear canal itself, the skin itself cleansing, it dies, it sheds, and it migrates outwards like a conveyor belt. However, when you've got a retraction pocket, so when the top part of your eardrum, the pars flaccida, is sucked in, and again normally it's at the top back region of the eardrum, the posterior superior quadrant, this skin collects and it gets infected, and that's called a cholesteatoma. And you get different grades of cholesteatoma. You can get an early stage cholesteatoma, which fortunately this appears to be the case, or you can get a kind of a grade 2, grade 3. And this cholesteatoma, this dead skin, it just collects as a pocket of dead skin, and that skin gets infected and it grows and grows and grows. And not only does it grow outwards towards the ear canal, but it also grows inwards into the middle ear. And then it can start affecting all the middle ear bones, the ossicles, the hammer, anvil, stirrup bones. It can cause disease of that. It can infect the mastoid bone, the bone behind the ear. It can affect the temporal bone. So the ear canal itself is made up of the temporal bone. It can cause disease to the facial nerves. So you can get Bell's palsy on one side. That's when it's something like you've had a stroke, your face droops on one side. That can continue, and it can cause, in the worst case scenarios, a brain abscess, meningitis, because it can grow upwards towards the dura, where the meninges are, so it can cause meningitis. In other words, it can be life-threatening. So you can see I removed that outer plug of dead keratin, and now this is the cholesteatoma. It's the main part of the cholesteatoma that's stuck in the retraction pocket, and you can see the top part of the eardrum very, very red. It's inflamed. It's got vascularis there, and there's a severe retraction. And again, I'm being so delicate because if this is in the middle ear, I don't want to be removing this because you could cause kind of trauma to the patient. That would need to be done under general anaesthetic, under surgery. So I'm just delicately just feeling this, just kind of getting a feel of it. Is it in the middle ear? And fortunately not, it just peeled away. And you'll see in a moment, so the top part, so that's where all that red, the inflammation, that's where the eardrum sucked in, and that's a retraction pocket. That's where that plug of dead skin was collecting inside that retraction pocket. And you can see some fresher layers of dead skin around there, the whiter layers, and it gets a bit more yellow. So the whiter layers are the fresher layer of dead skin. So that skin is trying to migrate off the eardrum out of the ear canal, but it's getting stuck in this retraction pocket, and this is a bit more yellow. So this is still dead skin, but it's been in there for a bit longer. It's oxidized. So we're hoping that, so obviously this patient's been referred to ENT, and I'm just hoping that it hasn't caused any necrosis, so disease, erosion of the middle ear bones or structures. The patient did suffer from a bit of vertigo in a moment, so you'll see him move slightly, not yet, but a bit further on. And what I'm trying to do here now, awaiting this with ENT is a long time because of the pandemic, so I could have advised the patient if possible, if they can go private, it would be better for them. But I'm just trying to remove as much dead skin as possible. And again, I'm just touching this, I'm just trying to evaluate what's going on here. And you can see it's a bit of a swelling there, so I'm leaving that. I'm happy with what I've done. And the patient was comfortable throughout. So at all stages, I was just trying to make sure if the patient was comfortable, because if the patient wasn't comfortable, I would have stopped immediately. Because it's hard to tell whether this cholesteatoma was quite deep into the middle ear. Because the patient was very, he tolerated the procedure very well, I could be rest assured that it wasn't, and it was more externally in the outer ear at this stage. So I did a pressure test, tympanometry, and that diagnosed bilateral glue ear as well. So when the eustachian tube is blocked, not only does it suck the air out to the middle ear, and it causes this retraction pocket like I explained earlier, fluid can't drain, and this fluid builds up behind the eardrum, and it collects, and you develop what we call acute otitis media with effusion, which is more commonly known as glue ear. So I recommend it. So this is where patient slightly got dizzy. So just wanted to see if I could get it. It's very mild dizziness, but I just left it at that stage. I don't want to cause any injury or trauma to the patient, and that's the final view. So yeah, recommended some nasal decongestion sprays to help unblock the eustachian tube. Recommended the Otavent nasal balloon, which is a special balloon that you inflate using your nose, and it tries to stretch open the eustachian tube to allow fluid to drain and air to enter to pop the eardrum back out. And obviously refer to the GP for some antibiotics, and urgent referral to ENT, but the patient may well go privately. I hope you enjoyed that video, guys, and it was informative and educational, and I hope you're all keeping well and safe. Thank you, bye.